Okay, thank you very much for the introduction. And first of all, I would like to thank Jeff and Jorn for the invitation. And it's great to be back in face-to-face events. This was greatly missed. So I'm going to talk to you in the next 20 minutes about clinical care pathways for the risk stratification of patients. This is a brief overview of my talk. I will start by the need for awareness and risk stratification, how to design a risk stratification pathway, and I will give you an example of what we have been doing in London for the last 8 years, the Camden and Islington pathway. So you have seen this slide many times. NAFLD is very, very common, 25% of the population. But what is quite astonishing in my view is the disparity between the estimated prevalence and the actual diagnosis and recording of the disease. This comes from 4 different databases, UK, Italy, Spain, Netherlands, primary care, and you see that the coding of patients as having NAFLD ranges from 0.3 to 2.5%. So underestimated by at least 10 to 20 times. So how can you risk stratify? How can you find patients with advanced fibrosis if you don't even know that patients have the disease? And at the moment, the patients we receive in secondary care, they are diagnosed by chance. There are absolutely no formal screening strategies. There are multiple guidelines that mention things that are not done. And you either get diagnosed with NAFLD because there is an incidental finding of steatosis on an ultrasound that you do for another region, or because you have a health check, and then they find abnormal transaminases, and this prompts investigations. And then when we look at how NAFLD is assessed, this becomes even more discouraging. This is from a study in the UK 6 years ago, but I can tell you that very little has changed. And you can see the blue bar that you can't see actually is what is routinely performed in primary care. And you can see that AST, for instance, that is essential for any first steps test that you use, be it FIB4, NAFLD fibrosis score, AST to ALT ratio, is only performed in 1/3 of the cases. And I won't even start talking about FIB4, ELF, biopsy, or whatever else. Now, when we talk about risk stratification, I'm talking here as an hepatologist, what are we looking for? We know that cardiovascular disease is the main cause of death, and all these patients need to have a management plan. But in which cases does a hepatologist need to drive the care? This is the main question. The liver disease is only the 3rd cause of mortality. And what we need a kind of a change of perspective, and we need multimorbidity, patient-centered care models so that liver disease is recognized and inserted in a kind of a metabolic panel of disorders. You can see in the natural history of patients with NAFLD and NASH that the mortality actually splits for patients who have advanced fibrosis. And it might well be that a patient with an F1 and F2 will probably die from cardiovascular disease before he or she has the time to develop complications of cirrhosis. So when we're talking about designing a risk stratification pathway, first of all, we need to engage with stakeholders, because this is a disease that is not primarily seen by hepatologists, and you will never succeed in developing such a pathway if you don't engage with the people who primarily see the patients. We need consensus, We need to provide very clear guidance because, for instance, primary care physicians are very busy. For us, it's all about liver disease, but they have to look at patients with dementia, with cancer, and they need very clear guidance. We need to educate, and we need to evaluate what we are doing and see how we can improve. And such a pathway should be based on evaluation of fibrosis. What we want to see as hepatologists is patients who have advanced fibrosis. We need an easily accessible first-line test that is automatically calculated so that people do not have to do extra effort to calculate this, and that will not break the bank. And this test needs to have a very high negative predictive value so that patients who have low scores can be discharged. Unfortunately, we have such scores, and we have both the FIB-4 and the NAFLD fibrosis score. They're more or less equal, but I think for simplicity, the FIB-4 is much simpler to use and much easier to calculate. And I think what is crucial here is to try and get this automatically calculated. Like the GFR is automatically calculated, you get the values, you have a patient, the patient gets coded as having NAFLD, the FIB-4 is then automatically calculated, and the healthcare provider gets a prompt on what should be done with the patient. And you can see that this test works as a traffic light. You get low values, it means that the patient is not at risk of advanced fibrosis. The patient can be reassured and reevaluated in 3 years. You get an indeterminate score, you need further testing. And you can see that by using this, 60% of the patients can be reassured. And I mean, this is a very important slide because it shows that for patients who have a low FIB-4 score over a 10-year period, there are absolutely no liver-related events. So this is quite important when you try to persuade people on how to use such pathways. This is a proposed algorithm, and you can see that you start with a low risk, with an inexpensive test with a high negative predictive value. Those with an indeterminate risk need a second-line test, and this can be based on what is locally available. It can be either a serum test, such as the ELF, or it can be elastography. And then the patients who are classified as low risk, we do not forget about them because they can still present with advanced fibrosis or cirrhosis later in their life, or we might have been wrong in our first assessment. So the recommendation is to rescreen them in 3 to 5 years. I will show you what we did in North London. It's now quite established, but it took a lot of time to set up and a lot of resistance. So first of all, this is what I'm talking about when I'm saying clear guidance. Instead of starting with a NAFLD pathway, we provided very clear guidance, step by step, on what to do with abnormal liver tests. So this was very highly appreciated because it made the life much easier for the primary care providers. And then it is quite important that when the patient was coming to us, the patient already had an ultrasound, already had a liver screen, which was negative. And what we discussed, and this is why I'm saying seek consensus, we asked, what would you prefer? What is easier for you? And the primary care provider said that it would be easier for them to do an ELF test because they would be in control of both the testing and the referral. And how they did it was that the patient was coded as having NAFLD, the FIB-4 was calculated, and if the FIB-4 was indeterminate, there was already a serum sample which was stored and was sent for the ELF measurement. And we were also able, because of the volume of tests we were doing, to negotiate also a substantially lower price for the ELF. And then you can see that there was also guidance for patients that stayed in primary care. I have a slide about this to show to you. And we did quite extensive modeling to try and understand what was the burden of referrals that we were going to see, because obviously we did not want to get overflowed. And what we have calculated was a 9% percentage of referrals of the patients entering the pathway. As I said, there was guidance for the primary care management of NAFLD, and we asked the GPs to do annual liver tests, to engage them in community programs with a target weight loss of 7 to 10%, to treat the components of the metabolic syndrome. We educated them about statins. There was this conversation before. I spent a few evenings going to primary care and speaking to GPs, and then to reassess the risk of advanced fibrosis after 3 to 5 years. This is from the early days of the program, but just to show that the coding doubled within 2 months of starting this exercise. And then these are the first 2 years of the program. You can see almost 1,500 patients entered, and sorry. The referral rate was a bit higher, 19%. But importantly, of those people who were referred, 30% had advanced fibrosis. One in 3, and we're talking about the pre-test probability when the patients started their journey in primary care was less than 5%. And we were able to compare this to, first of all, to a historic cohort just before the program started, and secondly, to patients who were coming to us outside this pathway. And you can see that the standard of care is 7.7%. So by using this algorithm, you improve the detection of advanced fibrosis and cirrhosis more than 4 times. You can see this was quite troubling. We didn't find a reason for this. There was no consistent pattern, but 45% of the patients at risk were not referred. So this, there are similar examples in viral hepatitis, and it has to do with linkage to care. But it is interesting to see. And it is one of the cases where not only an intervention is more effective, but it also makes financial sense. You can see that this is the total healthcare spend, and this is specifically about the pathway, and you can see that it is 70% cheaper than the standard of care. And again, if you look at overall healthcare costs, a 2-stage pathway versus referring all the patients or biopsying all the patients, you still get savings of at least 20% from an overall healthcare perspective. These are the recent Easel guidelines on non-invasive tests in testing in low prevalence settings. And again, I think they provide a quite comprehensive framework on how to use non-invasive tests. And it is important that in low prevalence populations, the non-invasive test should be used for ruling out rather than diagnosing advanced fibrosis. That's why you need a simple test with a high negative predictive value. And then you cannot use them in the general population. You will get too much noise. You need either risk factors or a positive diagnosis of NAFLD first. And then I talked already about automatic calculation. Now, this slide, what I want to say is that there is no non-invasive test at the moment that on its own is as good as a liver biopsy for diagnosing patients. We went through this exercise. We modeled extensively. The minimum sensitivity and specificity that a non-invasive test should have to diagnose cirrhosis equally to liver biopsy is 94% sensitivity, 85% specificity. There is no such test. You need to use combinations. And again, the two combinations, when the patients come to secondary care, FIB4 and ELF, are not enough. You need a third test. And what we have shown, again, is that with a relatively low ELF cutoff of 9.5, you need a stiffness of above 8. And this is the patients that then should move to liver biopsy. Now, in the last 2-3 minutes of my talk, this I think is a crucial question. Is there a rationale for targeted case finding? Because there are guidelines, but at the moment these guidelines are not followed. These are some studies that have looked at possibility of case finding. The first one looked at all comers above the age of 45. 5.6% had a FibroScan of above 8. With a positive predictive value of 40%, the result is probably 1.5 to 2%. Again, if you look at high-risk groups like type 2 diabetes or alcohol, then this percentage increases to 17% to 25%. And this slide I unearthed from a systematic review, and maybe it is for discussion, particularly after John's talk. But you can see you can also not rely on a single determination of a liver test, because of those deemed to be at high risk, the majority had normal liver tests. So unless you follow them up longitudinally, then abnormal liver tests on their own are probably not enough. This is what Easel recommends at the moment. These are the recent guidelines that we published, showing that recommending the use of FIB4 in patients who have metabolic risk factors or alcohol, but we do not know exactly yet which groups we should target, because we're not talking now about an intervention in a few centers of excellence, but something from a wider healthcare perspective. And the data and the cost effectiveness data, importantly, are just not there yet. This is a European project, the Liver Screen project, which continued despite COVID. You can see the rationale there is to screen 30,000 people in Europe above the age of 40 with a FibroScan and see what the yield is of advanced fibrosis and cirrhosis, and from there work backwards to find out which the best groups to target might be. So in conclusion, we need two-step strategies for risk stratification. We need to use the FIB4 as the first step and be consistent in our message to non-hepatology specialties. Nothing is, nothing is perfect, but we need to start from somewhere, and something is better than nothing. And then the populations for case finding need to be prospectively assessed. Thank you very much for your attention.